Okay, let's dive in. We're looking at a specific but really important topic today, renal cell carcinoma, or RCC. You sent us some revision notes covering this, and our mission is to navigate through them together, pulling out the absolute highest yield information.
Exactly. Revision notes can be dense, just fact after fact.
Totally. So we're going to break this down, make sure the core concepts are clear, and help you lock in the details that matter most.
Think of this deep dive as walking through the essential story of RCC, as told by your notes. From understanding what it fundamentally is to how it behaves, how it's spotted.
How doctors cackle it, and what
Yeah.
the outlook looks like.
Yeah,
Everything we discuss comes directly from the material you've shared.
right. So shall we start with the basics? What exactly is renal cell carcinoma?
Let's do it. The notes define it for us.
Yeah.
It's a type of cancer that starts in the kidney, specifically from the cells lining the tiny tubes inside the kidney called the renal tubules.
And it's not a minor player in kidney cancer, it's the big one.
Yeah, the notes highlight that it's the most common primary renal cancer, accounting for a significant, 80% of cases? Something like that?
Around 80%, that's right. Significant number.
Now, historically, you might have pictured someone with RCC presenting with a very specific set of symptoms, that classic triad.
Mm.
A lump or mass you can feel in their abdomen, pain in their side or flank.
And visible blood in their urine, haematuria, maybe weight loss too.
Exactly. But that classic picture, though, the notes make it clear, that's actually pretty rare now.
Mm-hmm. And here's where it gets really interesting and crucial from a modern practice perspective. RCC is often found incidentally.
Incidentally, meaning like completely by chance.
Yeah. Someone has a scan, a CT scan or an ultrasound for something else entirely, like maybe abdominal pain or another unrelated issue, and boom, there's a kidney mass.
Oh, the notes say over 50% of cases are found this way today. That's a huge shift.
It really is. But, and here's the flip side, the notes point this out too, despite being found incidentally so often, a quarter of people, that's 25%, still have advanced disease when they're diagnosed.
Okay, so incidental doesn't always mean early stage. That tells you something important about how this cancer can behave, I guess.
Absolutely. It can progress silently. So tracing it back, it originates from those renal tubule lining cells.
Right, and the notes link it to changes on chromosome 3 and mention it can be inherited, hereditary, or not.
Mm-hmm. And there are different types or subtypes listed like clear cell, papillary, and chromophobe. Those are the main ones mentioned.
It's also worth remembering that not every mass in the kidney turns out to be cancer. The notes remind us about 15% of renal tumors are actually benign.
Good point. And they list other types of kidney tumors you might encounter, just to provide context. Things like transitional cell carcinoma, oncocytoma, Wilms tumor.
Often seen in kids. Wilms. Right?
Yeah, typically. And angiomyolipoma. It's a complex area, and imaging is really key to trying to figure out what you're looking at initially.
Okay, so we know what it is and where it starts. But why does it happen? What causes it?
Well, the notes are quite direct here. The exact cause isn't perfectly understood. It's complex.
Right. But they do provide a solid list of identified risk factors,
Yeah.
things that increase a person's chance of developing RCC.
And this list is definitely high-yield information. You should know these.
Okay, let's run through them. The notes mention having a genetic predisposition. Smoking, that's a big one for many cancers.
That's a huge one. Also, obesity, exposure to certain chemicals, high blood pressure.
Specific genetic syndromes like von Hippel-Lindau disease and tuberous sclerosis.
Mm-hmm. And having chronic kidney disease or being a renal transplant recipient.
That's quite a list. You could maybe group those to help remember them, like lifestyle factors.
Yeah, like smoking, obesity, high blood pressure, then the genetic conditions like VHL and tuberous sclerosis.
And then existing medical conditions like CKD or having had a transplant.
Exactly. Understanding these factors is vital because it hints at who might be at higher risk,
Mhm.
It informs discussions around prevention or potential screening strategies down the line.
Makes sense. Okay, moving from the why to the how, the pathophysiology. How the disease develops and behaves, as outlined in the notes. It starts, like we said, from the kidney tubule lining.
Right. But the crucial point about its behavior, and the notes emphasize this, is its capability to invade nearby tissues and, importantly, to spread to distant organs, metastasis.
And that ability to metastasize is precisely why staging, understanding the extent of the disease, is so fundamentally important when it comes to RCC.
Absolutely. The notes also mention that underlying genetic and molecular abnormalities drive this whole process, though they don't go into massive detail on the specifics.
Okay, Given that not every kidney mass is RCC, what else needs to be on the radar when a lump is found? The notes give us a differential diagnosis list.
Yeah, other things it could be. This includes other tumors starting in the kidney itself, like the transitional cell carcinoma, oncocytoma, or Wilms tumor we mentioned earlier.
Right, those again.
But it's also important to consider that a cancer that started somewhere else in the body could have spread or metastasized to the kidney. That can happen too.
Ah, okay, so secondary cancers in the kidney. And how do doctors tell them apart?
Well, the notes reinforce that differentiating between these possibilities relies heavily on imaging combined with histopathological examination. So, looking at the actual tissue under a microscope to see what kind of cells are present. That's the definitive way.
Got it. Okay, let's zoom out a bit and look at the bigger picture. Who gets RCC and where? The notes give us specific epidemiology data focusing on the UK context.
And it is a common type of kidney cancer there, making up the majority of cases. Around 4,000 new cases diagnosed each year in the UK.
Okay, 4,000. And the demographics. Who's most affected?
The notes say it mainly affects individuals aged 60 to 70, and it's slightly more common in men than women.
And it ranks as the 7th most common cancer overall in the UK, making up about 4% of all new cancer cases.
That's right. Interestingly, the notes specify that the incidence is actually highest in the very elderly, particularly those aged 85 to 89. A significant chunk, 34% of cases, occur in people aged 75 and over.
Wow, okay. That's quite striking. Any other variations mentioned?
Yeah, the notes also point out some differences. There's a higher incidence in more deprived areas, and interestingly, a lower incidence in Asian and Black ethnic groups compared to others.
Huh. And that hereditary aspect we touched on.
It accounts for around 2 to 3% of RCC cases, according to the notes. So not the majority, but still significant for those families.
And what about trends over time? Is it becoming more or less common?
The notes show the incidence actually increased by 3.1% annually between 1993 and 2014, and projections indicate a further 15% increase in kidney cancer incidence in the UK is expected by 2038-2040.
So it's on the rise. These numbers give you a sense of the scale of the problem and highlight particular populations or trends that are important for, public health efforts.
Definitely. It frames the significance of understanding this condition.
Okay, let's circle back to how the disease actually shows up in people, the clinical features. We talked about that major shift towards incidental findings.
Yeah, and the notes are very clear. Over half of cases are asymptomatic, meaning they have no symptoms at all, and are discovered incidentally during scans for other things.
And just to really hammer this home, that historical classic triad of flank pain, haematuria, and an abdominal mass.
Rare. The notes explicitly state this is rare in modern clinical practice, so don't expect to see it often.
Good to know. So when symptoms do occur, what are the common ones listed?
The notes list haematuria, blood in the urine, pain in the flank or abdomen, maybe a mass that can be felt, fatigue, weight loss, and sometimes fever.
Okay.
Yeah.
Any other potential signs?
Abdominal swelling or maybe changes in kidney function tests could be hints too.
And what about signs that might point towards more advanced disease?
The notes specifically mention a right-sided varicocele, that's swelling of veins in the scrotum, specifically on the right and bilateral leg swelling. Those can be red flags for advanced RCC involving major veins.
Right. And remember that concept of paraneoplastic syndromes.
Ah, yes. The conditions caused by substances the tumor produces. The notes state they occur in about 30% of cases. We'll explain them properly when we talk about complications later.
Okay. The notes also list signs specifically related to metastasis, the cancer spreading. What are those?
Things like fever again, unexplained weight loss, a persistent cough, bone pain, and enlarged lymph nodes or adenopathy.
And it's vital to know the common places RCC spreads to, the notes mention.
Yeah, nearby structures, lymph nodes, major veins like the vena cava, and distant sites like the lungs and bones are frequently mentioned. Lungs and bones are very common sites for RCC met cells.
All right, so if someone has symptoms or a mass is found incidentally, how do doctors figure out if it's RCC and how far it's spread? The investigation process laid out in the notes.
Okay, so a critical starting point mentioned is the suspected cancer pathway referral guidelines, especially the 2-week wait referral.
Right, the 2-week rule. Who does that apply to here?
Anyone aged 45 and over with unexplained visible haematuria, meaning they can actually see blood in their urine, especially if there's no UTI, or if that visible hematuria continues or comes back even after treating a UTI. They need an urgent referral.
That's a key point for timely diagnosis, absolutely.
Yeah.
Then imaging that seems central.
Totally central. The notes highlight the abdominal CT scan as the primary method. It's not just about finding the mass. The CT helps assess how much the tumor has grown, if it involves major veins or lymph nodes, and checks the adrenal glands sitting on top of the kidneys.
And ultrasound.
Abdominal ultrasound is also mentioned as an adjunctive tool used alongside CT. It's particularly helpful for distinguishing different types of kidney masses. Is it a solid tumor, a simple fluid-filled cyst, or maybe a more complex cyst that needs a closer look?
Okay. And MRI, when does that come in?
MRI is used when a CT isn't suitable, perhaps due to an allergy to the contrast dye or when more detailed images are needed. It's particularly good for evaluating if the cancer is invading into kidney structures or major veins.
And they also need to check the chest, right?
Yeah. Yes, a chest CT scan is recommended as part of the initial workup to check for spread to the lungs, since that's such a common site.
Okay, imaging covered. What about blood tests?
Yep, blood tests are part of the picture. Renal function tests are obviously crucial since it's a kidney cancer. The notes also mention tumor marker tests, although RCC doesn't have really specific, universally reliable tumor markers like some other cancers do.
Right. Now, about getting a definitive tissue diagnosis, a biopsy, how does that fit in? The notes seem a bit nuanced here.
They are. The notes state that a definitive diagnosis is typically made either by biopsying metastatic sites if the cancer has already spread or after the kidney is surgically removed in a nephrectomy.
So often diagnosis is confirmed after surgery.
Often, yes. However, they specify scenarios where percutaneous renal tumor biopsies taking a sample through the skin with a needle are used.
Like when?
These include getting histology for masses that look uncertain on scans, maybe helping select patients who might be suitable for active surveillance instead of immediate treatment.
Just watching it closely.
Exactly. And also guiding treatment decisions, particularly in metastatic disease, where knowing the subtype might influence drug choice. So while not always done up front for a small, localized tumor, biopsies have specific important roles.
Okay, that clarifies it. Any other important evaluations?
Yeah, a full renal function evaluation is key, especially if there's already impaired kidney function. This might involve a special renal scan or calculating the eGFR.
And genetic evaluation.
That's recommended for certain patients, specifically those aged 46 or younger, especially if they have risk factors like tumors in both kidneys, multiple tumors, a strong family history of RCC, or specific histology types that suggest a hereditary form like VHL.
Gotcha. And ultimately, all these investigations feed into understanding the staging and evaluating for metastasis.
Which the notes emphasize is absolutely crucial because it dictates the entire treatment plan and prognosis. Everything hinges on the stage.
Okay, so let's talk about that staging system. It's the common language, right?
Yeah.
The notes mention the TNM system, specifically the 2017 version.
That's the standard. TNM stands for primary tumor, T, regional lymph nodes, N, and distant metastasis, M.
Let's quickly break down what those mean based on the notes. T is about the primary tumor.
Yeah, its size and how far it has grown. TX means it can't be assessed. T0 is no evidence of it. T1 is a tumor 7 centimeters or less, still just in the kidney.
T2 is bigger, over 7 centimeters, but still just in the kidney.
Right. T3 means it's extended into major veins nearby or into the fatty tissue surrounding the kidney, the perinephric tissues.
And T4 is the most advanced local growth.
Yeah, T4 means it's grown beyond the tough layer around the kidney called Gerota's fascia and maybe into the adrenal gland above it.
Okay, that's T. Then N is for regional lymph nodes.
Simple here. NX means they can't be assessed. N0 means no spread to nearby lymph nodes. And 1 means there is spread to those regional nodes.
Got it. And finally, M for distant metastasis.
M0 means no distant spread. The cancer is contained locally or regionally. M1 means there is distant metastasis. It's spread to organs far away, like the lungs, bones, liver, brain.
Okay. And these T, N, and M categories are then combined into overall stage groupings, right? Stage 1, 2, 3.
Exactly. Stage I is T1, N0, M0, small tumor, no nodes, no mets.
Stage 2 is T2, N0, larger tumor, but still no nodes, no mets.
Stage 3 gets a bit broader. It includes T3 tumors that haven't spread to nodes, T3, N0, M0, or any T1, T2, or T3 tumor that has spread to regional nodes, so T1, T3, N1, M0. Basically, significant local growth or node involvement, but no distant spread yet.
Okay. And stage 4 is the most advanced stage?
Correct. That means either a T4 tumor, regardless of nodes or mets, T4, any M0, or a tumor of any T or N category that has spread distantly. Any NM1. If there's M1, it's stage 5.
Understanding this system is absolutely fundamental then, because as the notes keep saying, the stage dictates everything that comes next: treatment, prognosis.
It's the roadmap. You have to know the stage.
So with staging understood, how do doctors actually treat RCC? The notes make it very clear. Treatment is highly dependent on that stage we just discussed.
Absolutely. It's not one size fits all. The main categories of treatment options listed are surgery, targeted therapy, immunotherapy, and sometimes radiation therapy.
Okay, let's start with surgery for localized RCC cancer, still just in the kidney.
Right. For that, the notes say nephron-sparing surgery or partial nephrectomy, where they just take out the tumor and a bit of healthy tissue around it, is generally preferred if possible. The goal is to preserve kidney function.
Makes sense. But removing the whole kidney, radical nephrectomy, is still an option?
Yes, definitely an option, especially for larger tumors or if a partial isn't technically feasible. Lymph node removal, lymphadenectomy, is sometimes done for staging, but the notes point out the survival benefit in localized disease isn't really certain.
What if the tumor has grown into a vein but hasn't spread far away?
If there's a tumor thrombus, like a clot of cancer cells in a major vein but no distant mets, a thrombectomy to remove that clot can be performed along with the nephrectomy.
And what about for a disease that has spread, advanced disease?
Cytoreductive nephrectomy, removing the primary kidney tumor even when there's already distant spread, is mentioned. But the notes specify this can sometimes be more palliative, meaning aimed at relieving symptoms or maybe improving response to other treatments rather than cure.
Are there alternatives to surgery for localized disease? Maybe for people who aren't fit for a big operation?
Yes, the notes list alternatives for selected patients. These include active surveillance, basically just watching it closely with regular scans.
For very small or slow-growing tumors, perhaps.
Likely, yes, and ablation techniques like cryoablation, freezing the tumor, or radiofrequency ablation, heating it.
How do those compare to surgery?
Well, the important caveat from the notes is that while these techniques might have lower morbidity, fewer complications maybe, they also tend to have higher recurrence rates compared to surgical removal. So, trade-offs to consider.
Okay. Now, for advanced or metastatic disease, what's the standard approach?
This is where systemic treatments, the drugs that treat the whole body, really become standard.
Like chemotherapy.
Actually, the notes point out that standard chemotherapy is often ineffective in RCC. It's generally not the go-to.
Oh, interesting. So what is used?
The focus is much more on immunotherapy and targeted therapy. The notes list older forms of immunotherapy like interferon alpha or interleukin-2.
Which had pretty significant side effects, right?
They could, yeah. But crucially, they mention newer drugs. There's targeted therapy drugs that target specific molecular pathways the cancer uses to grow. Examples from the notes include sunitinib and pazopanib.
Those are TKIs, tyrosine kinase inhibitors.
Exactly, they block key growth signals. And everolimus is another targeted agent mentioned.
And newer immunotherapies.
Yes, the notes specifically highlight a combination therapy mentioned for untreated advanced RCC, nivolumab and ipilimumab. These are checkpoint inhibitors, a type of immunotherapy that helps the body's own immune system recognize and fight the cancer cells more effectively. These have really changed the landscape for metastatic RCC.
So targeted therapy and immunotherapy are the mainstays for advanced disease.
Generally, yes, often considered for specific subtypes too.
What about local treatments for metastases, if it's spread to just one or two spots?
That can be considered for selected patients. The notes list various types of radiotherapy, like for brain metastases or stereotactic body radiotherapy, SBRT, to target tumors elsewhere very precisely. Surgically removing isolated metastatic lesions, called metastasectomy, is also an option for some.
Okay. And specific mention of bone metastases.
Yeah, for bone mets, the notes mention bisphosphonate therapy, specifically zoledronic acid, to help strengthen bones and reduce skeletal-related events like fractures or pain.
And of course, long-term monitoring and follow-up are needed.
Essential for managing the disease and catching any recurrence early.
What about adjuvant therapy? Treatment after surgery for high-risk localized disease.
It's considered, the notes say, in high-risk patients whose cancer was removed. But they add that there are limited approved agents specifically for this use, so it's an area still evolving.
Right. This really shows how complex and personalized the treatment approach is, guided so heavily by the disease stage.
Absolutely. Stage is everything.
Okay, let's wrap up by looking at the outlook, the prognosis, and potential complications mentioned in the notes. This is obviously critical information.
Definitely. And the notes are absolutely clear here. Prognosis vary significantly with disease stage. That is the single most important factor influencing survival.
So finding and treating it early, when it's localized, offers a much better prognosis.
Much better. As you'd expect, advanced cases where the cancer has spread to distant organs, stage 4, have a poorer prognosis.
Do the notes give any specific survival stats?
They provide figures for England. The proportion of patients still alive is around 79.3% at 1 year after diagnosis, 63.8% at 5 years, and about 51.8% at 10 years.
Okay. Is there any good news in those trends?
Yes, the good news highlighted is that kidney cancer survival rates are improving over time, and survival is highest for those diagnosed under the age of 50.
And again, survival rates are dramatically higher when diagnosed at the earliest stage.
Massively higher. It just reinforces that point about incidental findings, potentially catching things earlier, even if some are already advanced.
The notes also compare England's survival rate to the European average.
Yeah, noting that England's 5-year relative survival for kidney cancer is currently lower than the European average. Room for improvement there.
And they link back to risk factors again.
Mentioning that smoking and obesity are linked to prognosis, not just the risk of getting it, but potentially how well people do. And they touch again on those genetic links to specific RCC subtypes, suggesting maybe these could lead to targeted screening down the road.
Makes sense. Okay, what about potential complications? What can go wrong?
The notes list several issues. One major one is metastasis, obviously the cancer spreading. Common sites mentioned again are lungs, bones, and liver.
Okay, what else?
Other complications can include the tumor growing and invading nearby structures, which can cause pain or lead to impaired kidney function.
And those paraneoplastic syndromes we deferred earlier.
Right, they're listed here as potential complications. These are effects caused by substances the tumor releases. The notes give specific examples like polycythemia, that's too many red blood cells, and hypercalcemia, which is high calcium levels in the blood. These systemic effects can sometimes be the first sign of the cancer.
Wow. Okay. So we've covered a huge amount of ground today, really taking a deep dive into these RCC revision notes you provided. We've gone from the basic definition, understanding where it comes from, and the risk factors.
Through its often subtle presentation, how it's investigated, that crucial TNM staging system,
The whole range of tailored treatment options from surgery to immunotherapy, and finally, the prognosis and potential complications.
it's a lot, but hopefully breaking it down helps it stick.
Yeah, I think the key takeaways from this material really are RCC is common. It's often found incidentally now, which is a major shift. Staging is absolutely paramount because it drives all the treatment decisions.
And while it's complex, treatment is increasingly personalized, with targeted therapies and immunotherapies making a big difference, especially for advanced disease.
Exactly. Navigating these notes really gives you that structured, high-yield understanding of the condition.
Definitely. And thinking about how often this cancer is found incidentally and how strongly the outlook is tied to catching it early, it does raise a really interesting question building on this material.
Oh, yeah. What's that?
Well, what might be the most impactful path forward for improving outcomes in the future? Is it mainly about developing better, maybe more targeted screening methods for those high-risk populations we talked about?
Or perhaps leveraging those genetic insights more, finding individuals predisposed who might benefit from closer surveillance.
Exactly. Where should the focus be for the next big leap in improving survival? It's definitely something the information here prompts you to consider, you know?
That's a great thought to end on. Absolutely. Thanks for letting us explore this material with you in the deep dive. Keep working through these concepts, keep asking questions, and keep that curiosity alive.